Okay, so good morning, everyone. Today we're going to talk about cardiac catheterization risks and complications. So what is cardiac catheterization? It is one of the most widely performed cardiac procedures, and it can be either diagnostic in case of the angiogram or therapeutic for PCIs. And it's used to evaluate and treat conditions such as coronary artery disease, measuring hemodynamics for right and left side of the heart, cardiac arrhythmias, and valvular heart disease. So there are, as for any procedure, there are contraindications, but take note that there is no absolute contraindications for cardiac caths, mainly because the benefits outweigh the risks, and we usually manage them before bringing the patient for the procedure. So for example, severe renal failure. So this is part of our checklists. It's very important to check the patient's renal function because our procedures mainly use contrast medium. So as part of our checklist, we check the CIN-P. Well, who knows what CIN is? What does it stand for? CIN protocol?
Contrast-induced nephropathy.
Perfect. So contrast-induced nephropathy, it means that there is significant increase, 25% increase of the patient's serum creatinine after 24 or 48 to 72 hours after contrast administration. So it's very important that patients receive fluids pre and post procedure and even intra procedure. So next is contrast allergy. Of course, we always ask the patients if they're allergic to anything. If they're allergic to contrast, we give them medications, and we will discuss more about this later on. So next is severe hypokalemia or hyperkalemia, or any electrolyte imbalances, because of course they can induce dysrhythmias during procedures and even cardiac arrest. Coagulopathy, so it's important to check if the patient is on warfarin or any NOACs or DOACs, and make sure we check the INR pre-procedure, and if not, they need to discontinue the medications 48 hours prior. So this is to reduce the risks of bleeding. So next, moribund patient. This just means the patient is terminally ill or is at the point of dying. It just means that there's more harm than good for the patients. So next is severe anemia. So this is important. We check all the blood results for patients coming in for procedures. So if the patient is anemic, we usually manage it days before the procedure. We give them medications or even blood transfusions. Pregnancy. So there are a lot of things going on for this one. First one is the contrast medium, and next one is the X-ray. So again, this should be discussed prior to doing the procedure. Make sure to weigh the benefits and the risks. But I think for the X-rays, they have a special lead to cover the belly. But I don't think there is, but we don't really use it here. If the patient comes for an emergency, there's still an MDT that should be done prior to bringing the patient in the lab. Next is active infection. So we don't normally bring patients who have active infections in the lab. It's either they already have antibiotics going on, or we treat them altogether before having the procedure. Okay, so we're going to discuss the complications. So they are more likely observed in people above 75 years and those with underlying conditions such as diabetes or kidney diseases. There are two categories. First is the acute complications. So they normally happen during the procedure or immediately afterward. And the next one is the long-term complications. They occur months after the procedure. So first, let's talk about the acute complications. So who can tell me what complication is this?
Chest pain.
Okay, yes, thank you. Chest pain or MI, myocardial infarction. So it generally occurs within 24 hours of the procedure. And it happens if a blood clot gets dislodged by the tip of the catheter during the procedure and completely blocks an artery. So it's very important that they are loaded with antiplatelets, and we use heparin during the procedure. Okay, so next complication. What is complication is this? Say it out loud. Stroke. So this stroke is an extremely rare complication. So it occurs if plaques break loose when the catheters are being threaded through the aorta. So normally, if patients patients who have coronary artery disease, they often have atheroma in the descending aorta or in the aortic arch. So if we use catheters, they could break the plaques loose, and the clots or the plaques would go to the brain and cause a stroke. So what type of stroke we can normally see as a complication for cardiac caths? What type of stroke? Ischemic stroke, yes, that's correct. So blood clots can form in catheters and travel to the brain if they break loose. So it's very important, again, for heparin or any anticoagulants, and also flushing the catheters. Make sure that you flush them before you use the catheter again. Air embolism, so make sure all the lines are free of air, the manifold and the indiflators, because they can cause stroke. Next, abnormal heart rhythms. So during the procedure, the heart may beat too quickly or too slowly. It's usually short-lived and can be treated with medications, cardioversion, or defibrillation, or even just a simple cough can reverse this. Sometimes we need to use do a temporary pacemaker or PPM. This is normally seen in TAVIs. And the most common is sinus bradycardia. So we'll talk more about this. Okay, so which coronary artery is the one in the picture above? It says so there. It's the right coronary artery. So normally, bradycardia is a predictor of RCA occlusion. So when you hear that someone or a STEMI or an inferior infarct is coming to the lab, what normally goes through your head? If it's an inferior STEMI, what do you think? What catheters do you prep? What medication do you prep? Atropine. Okay, so inferior STEMIs, they don't usually mean that it's an RCA occlusion. It can either be 80% RCA or 20% circumflex. This is because both coronary arteries supply the inferior wall. The RCA supplies the medial aspect of the RCA, or of the inferior wall of the heart, and the circumflex supplies the lateral aspect of the inferior wall. So why do you think an RCA occlusion induces a bradycardia? Any ideas?
That's where the SA node is.
Yes, that's correct. So as you can see on the photo below, the RCA supplies a lot of branches, or I mean, it comes several branches off of the RCA, and it supplies the heart's electrical conduction system. So at the top, you would see SA nodal branch artery, so that supplies the SA node. At the bottom, that's the AV nodal artery, supplies the AV node, and you have the RV branch, the acute marginal, and the posterior descending. So that's the reason why the patient presents with bradycardia. So let's talk about the conus artery. So the conus artery is that small artery. It's usually the first branch coming off of the RCA. And do you notice when the operator, they cannulate the conus right away, and they usually almost always just removes it? Do you know why? Anyone?
Because the pressure tracing is very damp against the...
Yes, that's correct. Why is it damp? Yes, that's correct. Because the conus artery is the first artery coming off of the RCA. So when you cannulate the conus, it means you're blocking the RCA as well. That's why the pressure is dropped. And you don't inject contrast when you are on the conus artery, because occasionally it induces VF or VT. So not all people have conus arteries. Only 45% of the population has them. It supplies the RVOT. It causes wedging and damping of the catheter tip pressure. So you would notice that the physiologist would give us a warning if there's damping. So prolonged inadvertent injection of contrast can cause VT or VF occasionally. Okay, next, what complication is this one? Anything? Yes, dissection. Okay, so dissection is a well-known complication of invasive procedures, mainly because we use catheters, wires. It's a split or a tear in the arterial wall, which compromises the lumen of the artery, reducing blood flow. So it's pretty common. We usually just treat them with stents. And there's also what you call spontaneous coronary artery dissection. So it dissects without any cause. It's a non-traumatic and non-iatrogenic separation of the coronary arterial walls, creating a false lumen. So the cause is still unclear with this. Next, oh sorry, can't see it. Anyone can decipher what this is? What complication? Can you see a complication there? Yes, this is not something you want to see first thing in the morning. It's coronary perforation. It can be caused by a wire exiting the vessel or by a tear in the vessel from balloon angioplasty, stenting, or rotational atherectomy. So it has 3 classes, 1, 2, and 3. We're not going to delve into this, but if you see a perforation, what do you need to prepare as a circulating nurse? Anything? What do you prepare? Perforation? Yes, that's correct. Covered stents. What else? So if there's perforation, there would be bleeding coming out of the coronary arteries. So what does it cause? Tamponade, yes. So you need to prepare a pericardiocentesis kit. So class 1 and 2 are usually managed conservatively without any specific treatment. And class 3, they're associated with rapid development of tamponade, the need for urgent bypass surgery, and a high mortality rate. So the treatment is balloon tamponade. So usually balloon tamponade, we do this if the perforation is at the distal artery, covered stents if it's proximal, pericardial drain, reversal of anticoagulations. But again, you reverse the anticoagulation if the stents and the wires are already out, because you would cause thrombosis, and this is usually more critical than perforation. So who has seen a perforation in real life, like in the labs? Can you share? What treatment did you?
So with perforation, the key really is to have a wire.
Mm-hmm.
So because if that happened without a wire,
Just block.
Patient will die.
Mm.
And also depending on the area, how massive the perforation is. So if there's a wire, the running nurse or circulating nurse should be really quick.
Yes.
In getting a balloon, whatever sizes, just get a balloon, get it inside, and then inflate it.
Mm-hmm.
And then the next thing will be prepare a pericardiocentesis kit, an echo, PTE, covered stent. So what are the covered stents we got at the moment? Same one.
Anyone? What term?
Yeah. Angiograph and papyrus. So we're going to replace the angiograph because it's an old bulky graft stent. The new one is papyrus, really thin, so it's really good. And what are the other things that we need? Oh, we can use a fat from the vessel. So you can get a fat from the radial artery, and then you can inject it in the perf area.
Mm.
That's one thing, but it's really difficult. You need a skilled operator for that. And the other one is a coil.
Yes, a coil.
So you can use a coil. What coil do we have in the lab?
MVP.
Yeah. So for those who are in CTO, we need to know that.
Well done.
Yeah, to
Exactly. Thank you, Rodney. So, what complication can you think about from this picture? So this is a femoral approach. So we have complications just for the access. So the ideal site of femoral arterial puncture is at the common femoral artery at the point approximately 1 centimeter lateral to the most medial aspect of the femoral head. So this is why you see operators doing fluoro with the forceps, is just to mark the location. So it's called Roop's rule. So there are complications if the puncture is below or above the bifurcation. You noticed before, if we convert to femoral access, there was a time that the operators are not allowed to do arterial punctures blindly. They usually they ask for a sonocyte, It's because to prevent these complications. So if the puncture is below the bifurcation, it can cause ischemic arterial complications and AV fistula, mainly because below the bifurcation, the artery is smaller. And AV fistula, because in this location below the bifurcation, the vein, the femoral vein and the femoral artery are close together. So, which is why more increased risk of AV fistulas. So if it's above the bifurcation, there's increased risk of retroperitoneal hemorrhage. It's because of the lack of underlying bone structure that prevents us from giving good manual pressure. Okay, so how long does an angioceal dissolves or gets reabsorbed in the body?
90 days.
Yes, correct, 90 days. So if you need to reaccess the femoral artery, you need to wait more than 90 days. However, you can still use it within 90 days, but it should be 1 centimeter proximal or distal to the previous arteriotomy. Okay, so this one. The photo on the left is the Cullen sign. It's bruising in the umbilical area. And the right is Gray Turner sign. It's bruising on the flank. So when do you see these signs? What complication of femoral access? Correct. So retroperitoneal hemorrhage. So it can mask as a vasovagal reaction. You get the same symptom, flank pain, hypotension, but this is the sign that you need to look for retroperitoneal hemorrhage. So to diagnose, you need a CT image of the pelvis. You need to have a fluid challenge with crystalloids and blood transfusion. And you need to use a balloon tamponade. So they usually use a contralateral access to stop the bleeding. Use of covered stents as well, femoral covered stents depending on the size. And in worst case scenario, you need an emergent surgery. Okay, what complication is this one? What machine is that? So kidney problems. So as you all know, the kidneys might be damaged when you have contrast dye given. So renal functions, again, should be checked first. IV fluids pre and post. And for those who are undergoing dialysis, they should have dialysis first. And also they should have a scheduled dialysis after the procedure. This one. I hope you can see it.
Is it allergy?
Contrast allergy. So you could get mild symptoms, feeling of warmth, nausea, vomiting. They occur only for a short period of time and do not require treatment. Moderate symptoms. You can have severe vomiting, hives, swelling. They occur in 1% of patients. And the severe, this is the anaphylaxis. You can give adrenaline intramuscular with this. It occurs in 0.1% of people receiving contrast medium, so very unlikely, with an expected death rate of 1 person in every 75,000. So reactions to contrast media are not a true allergy because there is no allergic antibody present that causes the reaction. So contrast media, they act to directly release the histamine and other chemicals from mast cells. So for seafood allergies or iodine allergies, they are not really the cause. They are not the cause of allergic reactions. Studies show that there are certain proteins in the seafood rather than the iodine that makes the person allergic to seafood. So anyway, we have a protocol here in the department that we give the hydrocortisone if they are allergic to iodine and seafood, just for precaution. Okay, so for long-term complications, instant Re-Stenosis. So you have seen this. So it's defined as a decrease in the luminal diameter by greater than 50% in the stented area of the vessel. It's caused by blood clots. So normally before the drug-eluting stents, we use bare metal stents. Who has been in the CathLabs when bare metal stents were a thing? Rodney. Yeah. So because of instant restenosis, they've created the drug-eluting stents because they are coated with medications that prevents blood clot formation. So the mechanism of restenosis, it has three mechanisms. The first one is neo-intimal proliferation. So when you do PCI, you balloon or the wires, they cause injury to the coronary arteries. So just like any other reaction to injury, the body, it results in platelet adhesion, thrombus formation, and monocyte infiltration. So the second is elastic recoil. Within hours after an angioplasty, the walls of the artery may start to recoil, gradually caving in to their original position. So it's not that the patient stopped, and it's not always that the patient stopped their dual antiplatelet. It's just there are some mechanisms that, that affect the arterial wall. So next is arterial remodeling. So we have two, positive and negative remodeling. So positive, it is the expansion in the external elastic membrane area. So you see on the picture, the upper one is the positive. So you have a plaque there. The membrane expands, but the negative remodeling, the elastic membrane shrinks. That's why the lesion, it's tighter than usual. So that's why operators do IVUS for these cases. Oh. So intravascular ultrasound show that negative remodeling accounts for 2/3 of lumen loss in restenosis following angioplasty. So IVUS guides them on what is the best step on how to go about this. So that's it. Any questions? Questions? Yes.
With the just like a refresher, it's a good topic because also for us who've been here for a while, it's like a good way to refresh with complications and risk.
Mm-hmm.
With the retroperitoneal, like you see with the Cullen side, Turner Gray side, let's say we're already suspecting that she has retroperitoneal bleed. So we go straight to CT scan. We won't like go back in and like check the arteries. Is it just go straight to CT scan?
Well, CT is a good way to check it. So that's why that way you will know how to treat it. So again, you can treat it with balloon tamponade. So according to the CT pelvis, if that's the way we're going to, then we need to bring him to the lab. So again, conservative treatments, you need to give them a fluid challenge and treat the symptoms.
So yeah. CT scan first and then
Yes. So it depends on the operator, but the diagnosis is for the CT pelvis. So just a bonus question. What do you think is the most or the worst artery that can be occluded? LAD? Anyone thinks otherwise? Yes, so it's LAD. Yes, Rodney, it's termed as the widowmaker. If you have a block in the proximal LAD, it's very dangerous because the LAD supplies a big portion of the heart wall. And the left main, if it's occluded, it's the mother of all widowmakers. So yes, that's correct. That's it. Any other questions? Okay, thank you guys for coming. There's just this evaluation that you need to fill out before you go. Thank you.